Good afternoon, everyone. Welcome to the last talk of the semester. My name is Dr. András Székely, and today I'm going to talk to you about emergency medical service and how imaging may facilitate the care of emergency medicine patients. So let's begin. An emergency medical system is an integral part of a well-functioning healthcare system. It is the first point of contact for the majority of people to healthcare services during emergencies and life-threatening situations, and it acts as a gatekeeper for secondary and tertiary services. The emergency departments or emergency rooms are divided up into 5 different levels, level 1 being the highest category. And the division is based on the number of patients that are admitted to the ED per year and the kinds of resources that are available. Level 1 is the highest level. It is found in major cities and it is associated with medical schools. Most specialists and subspecialists are on site and available virtually any time of the day, so they can treat any disease and trauma. As you go down to level 2 and 3, the number of specialists, subspecialists decrease, and surgeons might not be available 24 hours a day. And then level 4 and 5 facilities are found in rural areas where doctors might not be available all the time. So the goal of level 4 and 5 facilities is to stabilize patients and then send them over to a higher level facility. The mode of emergency healthcare delivery in pre-hospital environment evolved around 2 main models of EMS with distinct features. The first one is the Franco-German model, which is very popular in Europe and is utilized in Germany, France, Greece, etc. The idea behind this philosophy is to bring the hospital to the patient, to bring an ED equivalent doctor to the site of injury, and to bring sophisticated equipment to the site to treat the patient there. And so one advantage of this model is that a lot of patients are treated before bringing them to the hospital, and a lot of patients, when they are stabilized or treated and still require some hospitalization, they can bypass the emergency department and they can be transferred to the ward, for example, surgery or internal medicine directly. These patients are transported by land ambulance and helicopters, and as I said, this model is popular in Europe. In America, the Anglo-American model is widely used. The idea behind this model is for somebody to run out and get the patient and then bring them back as quickly as possible where they can be treated effectively. So most of the time, paramedics go get the patients. Paramedics, of course, are highly trained personnel who may perform CPR, do fracture splinting, full immobilization, etc. But the idea is for them to go get the patient and then bring them back through the ER as quickly as possible so that treatment can begin in the emergency department. Now, this model is, of course, or this model fits to TV because it's dramatic. A lot of people are involved. There's a lot of rush and noises, etc. So you can imagine that this type of model is what we see on TV. Series like ER or Grey's Anatomy have popularized this model. And as you can read here, United States, Canada, New Zealand, State of Oman, and Australia have adopted this model. In Hungary, we still utilize a mixture of these two. Most of the time, we utilize the Anglo-American model, but it's not quite clear what we're using. Okay, when patients are transferred to the ER, the process of triage immediately begins. This word comes from the French verb trier, which means to sort. And the idea behind triage is to select the sickest and the patients are at most danger of demise, and to put them with the right type of personnel so that they can get appropriate treatment as soon as possible. The goal of triage is to determine how sick the different patients are, to categorize them into a list of 5, to find out what their potential for demise is, to determine how quickly they need intervention and where we should place them, whether to place them in the waiting room or to rush them to, for example, the shock room immediately. Triage is of course carried out by specially trained nurses, but in certain situations, doctors can do that, or paramedics as well. The triage nurse is a very, very important element in the process of triage, because she or he is the one who assesses patients and reassesses patients continuously as they are waiting outside for treatment. He or she also needs to be able to communicate well with healthcare professionals and to document everything, because in all parts of medicine, documentation is key. He or she also needs to determine treatment locations, initiate treatment protocols, and participate in patient flow. Emergency patients are unique because they don't want to be at the ED, so their visits are unscheduled. They are usually anxious and distressed, and the healthcare providers and patients are strangers to one another. So it's not like when we go visit our GPs, whom we have known for years. Patients experience symptoms. They don't come in with a full diagnosis, and they span all ages. So in some cases, children are also visitors of emergency departments. And what's unfortunate is that these people often lack primary care. So they have multiple chronic diseases, for example, that for which they haven't received treatment, and that makes diagnosis and treatment even more difficult. The process of triage begins immediately as the patient walks through the door of the ER. There is that critical first look that the triage nurses do. This shouldn't take more than about 5 seconds, and it doesn't, because these people are usually experienced, and they can perform this quick check just by looking at the patient and determine breathing, disability, circulation, etc., and just to get a good impression of the patient. Then the patient needs to be screened for infectious diseases. Before COVID-19, most of the time this was done on paper. Patients were asked to fill out a questionnaire to determine whether they have any likelihood of infectious diseases. These days, when I'm recording this in December of 2021, the rapid antigen test for COVID-19 pneumonia is utilized for basically every patient who steps through the door of the ER. Of course, if the test is positive, then appropriate protective measurements need to be taken. Patients need to be separated from those who didn't test positive, and just like with every infectious diseases, but COVID especially, of which we don't know too much or we haven't had years of experience, we need to use the latest information and guidelines, which might change over time. And then the real or the main part of triage begins when patients start basically complaining, telling us their stories, why they came to the hospitals, do they have pain, what kind of injury they suffered, what was the mechanism of that injury, and they tell us about their concerns. Now these symptoms have to be objectified, and we have a very nice and thorough list put out by the Canadian Emergency Department Information System, which you feel free to read through. And for example, you can read here that patients might talk about abdominal pain or diarrhea. These are objective symptoms that are found in this booklet. And so parts of these symptoms might be patient driven, so things that the patients are telling us, like they have a swollen leg. And some of these are nurse driven, meaning that yes, the patient does complain of leg pain, but he or she also has a shortness of breath. In this table on the right, which I took out from an article, you can see the annual percentage of the different symptoms with which patients came in 2002. In November of 2002. So you can see here that musculoskeletal symptoms complaints were on the top of the list. 21% of patients came in with some MSK symptoms. Second on the list was abdominal pain, and then upper respiratory infections, etc. Now, today at Kennedy, this list would look something like upper respiratory infection, shortness of breath in number 1 and number 2 positions, and then musculoskeletal would probably be number 3 because of the vast amount of COVID patients that we have. Once we have the symptoms objectified and documented, the triage nurse needs to consider modifiers. They are listed under first and second order modifiers. So these provide additional acuity to the presenting complaint and help assign the appropriate CTES level. I'm going to talk about the CTES levels quickly, but you can see here that, for example, if patients are in severe respiratory distress and their oxygen saturation is below 90%, then that puts them in a CTES level 1, which is the highest category. That means that they need to be taken care of immediately. Or if they are in shock, if they are unconscious, or if they have acute central pain, then that puts them in CTES 2. If they suffered major trauma, such as ejection from a vehicle or a rollover, or they were on a motorcycle and they flew off of that motorcycle due to an accident, then that puts them in a CTES 2 category. And over here, you can see the different CTES levels. So level 1 is the blue one, which needs immediate attention by a doctor and by nurses. Here you can find major trauma or severe respiratory distress. The emergent category requires an attending doctor in less than 15 minutes and immediate nurse care. This would be moderate respiratory distress or suspected stroke, heart attack. An urgent category requires a doctor in 30 minutes, and it doesn't need to be an attending doctor, and it requires nurse care in 30 minutes. These patients would come in with mild respiratory distress and non-symptomatic hypertension, and then you can read the non-urgent is the blue one, and then the gray one is the non-urgent, which requires attention of a doctor and a nurse in about 2 hours. So these patients can safely wait outside under the watch of the triage nurse. Now, one important thing that I forgot to put in my presentation is the importance of security. You can imagine that in a waiting room, a lot of different patients can be stuck together at one time, and some of those patients might react to waiting differently. Some of the patients might be under the influence of various drugs or alcohol, etc. And so some patients might be violent. So security, the presence of security is very important in an ED to make sure that the personnel, the medical personnel, and the patients are safely together. So once we have considered the presenting symptoms and the modifiers, and we assigned a CTES category, level 1 and 2, of course, are treated immediately, and then level 3, 4, and 5 can be put out to a waiting room. And as I said, they should be continuously watched and monitored, and of course reassessed for any signs of deterioration. This is not a hospital waiting room. This is a private clinic in Debrecen, but it's so nice that I thought I would put it in here. Retriage is the triage nurse's duty. So as I said, CTES level 1 and 2 doesn't really count here because those patients have received immediate treatment or some form of care, and they are evaluated on a continuous basis. But in those patients who are put outside in the waiting room, they need to be checked based on their CTES level. So level 3 should be checked every 15 minutes, and then a level 5 patient should be checked every 60 minutes if they require that amount of time to receive treatment. And that's about that. And then we are finally here at radiology, at the radiology part of the talk, because there exists such a term as radiological retriage. This means that based on the results of imaging, patients can be moved up or down on the CTES level category. And I am showing you two examples over here. This is a coronal CT of a patient who came in complaining of lower right quadrant pain and was put in the urgent category, which is level 3. And then CT was performed, and we can see here that the appendix is dilated. It probably has thicker walls. There is fat stranding around it, and there are pockets of free air within the peritoneum. So this patient received a diagnosis of appendicitis with perforation and was immediately put in the emergent category. So this is radiological retriage at work. And then this is a patient that I have seen a couple of years ago. This man suffered trauma, blunt trauma to his chest on the right, and decided to come in 7 days later complaining of chest pain and dyspnea. So he was put under urgent category, and then we performed a chest x-ray and x-rays of the ribs and found multiple rib fractures. I'm showing you one over here, and total pneumothorax was diagnosed on the right with some hemorrhage. And so when we saw this patient was immediately moved up to level 2, which is emergent. Now, the different modalities in radiology can be utilized in various ways. One key theme is that imaging should be carried out without any unnecessary transportation of the patient. With X-ray imaging, transportation isn't required because we have these mobile units. Patients can be imaged either sitting or supine positions, for example. We don't use these films, X-ray films anymore, so there's no chemicals involved, and everything is quick and easy because of these DR and CR cassettes, which allow digitalization of images, so images can be sent out to the hospital DICOM server, for example, from where any treating physician can have access to those patients. Now, X-ray imaging is regularly done, for example, in the shock room or in the ward. We perform a lot of chest, abdominal X-rays, MSK X-rays, looking for pneumothoraxes, fractures, free air, etc. Here you can see a large aortic dissection on a chest X-ray, and here you can see a chest X-ray, but the disease wasn't in the chest, it was in the abdominal cavity. There is a large amount of free air under both domes of the diaphragm. Ultrasound can be safely performed on site, and even with these small equipments, we can generate great images. This is not an advertisement. I'm showing you this brand because this is what we have received and what we're using when we go, for example, in the shock room or in the ward to perform ultrasound examination. Now, the nice thing about this setup is that we can use a tablet or even our own smartphones, to generate ultrasound images, because all the necessary electronics to generate the ultrasound scan are within this transducer, and convex transducer, various linear transducers are available. So me and my colleagues, we like to use this type of equipment. On ultrasound, we might see gallstones with nice posterior acoustic shadowing. We might see gallstone again with posterior acoustic shadowing, some sludge in the gallbladder, normal bile in the gallbladder, and a thick wall of the gallbladder, and some free fluid surrounding the gallbladder. So this is cholecystitis with a gallstone. This image is probably of the iliac artery and vein. The vein is on the bottom, and you can see that it's more hypoechoic. It's probably non-compressible, so this is a thrombosis. A kidney stone is visualized here in the center of this kidney, and again, since it's a stone, it shows posterior acoustic shadowing. This kidney has dilated calyces indicated by these arrows, a dilated pelvis, and a dilated ureter, and there's a small stone in there. And this is an image of an aortic aneurysm with this crescent or moon-shaped thrombosis. So this would be the true lumen. If I were to turn on the Doppler, I would see color over here, but then this area would remain hypoechoic. In terms of ultrasound examination, we regularly perform the rush examination. The rush examination is a quick and easy way to determine between the four types of shock. So this examination we use and perform in the shock room. So over here on the left, you can see where we would place the curvilinear transducer. You can place it over the lungs to rule out the presence of pneumothoraces, although this is best performed with the linear transducer. Number 1 and 2 positions allow to examine the heart to look for pericardial effusion or indirect signs of pulmonary embolism. Position 4 is of Morison's pouch, which is the hepatorenal recess. This is the deepest part of the abdominal cavity when the patient is supine, and this is the first place we look when we want to diagnose free abdominal fluid. The splenorenal recess, number 5, is again used to look for free abdominal air or splenic rupture, for example. Number 3 is the inferior vena cava view. 7, which includes or which comprises multiple views, is the aorta view. And then 6 is the pelvic view, again to look for free abdominal fluid. CT is loved by various clinicians, especially traumatologists. Now, CT imaging is done 99.9% of the time in the CT ward, and then that 0.01% of the time it can be done on site. I have heard about it, and I have seen these smaller CT units that allow for on-site head CT imaging, or another company has a full body CT scanner which can be pushed around, but this is very rare. As I said, I have seen this in Vienna at the European Congress of Radiology, but I think that most hospitals have CT scanners which cannot be moved, so the patients need to be brought to the CT scanner. And so with CT, for example, with a non-enhanced CT, we can diagnose intracranial hemorrhage. These are calculated images of an ischemia in the MCA territory. The red and gray areas indicate good flow, and then this very dark area indicates hypoperfusion. There is blood over here within the sulci and cisterns. An aneurysm is visualized on this volume rendered image. So that's an image that was reformatted from the raw CT data. Pulmonary embolism the diagnosis of pulmonary embolism requires the administration of contrast media, iodine containing contrast media, don't forget that. Here you can see a pulmonary artery with a hypoechoic thrombus in it, or over here a thrombus which is in the left main pulmonary artery and in one of its branches. Dissection is visualized over here with the true lumen and the false lumen. Traumatic hiatal hernia would show up on an X-ray, but here you can visualize it on this CT image. Pancreatitis is seen over here. The pancreas is enlarged and it is surrounded by lots of free fluid. Urolithiasis on the left, and you can see it on this axial image and the coronal image. Kidney infarct is visualized here, and you can see that the left kidney enhances much less than the right kidney. And then finally, splenic injury over here. About 1/3 of that spleen doesn't enhance the contrast media. In my chest talk, I have talked about triple rule out CT, which is available, and it's a nice technique, especially in an ED setting, because a significant amount of patients come to the emergency room due to chest pain, and a lot of things can be behind chest pain, but these 5 main disorders, and especially these 3, so acute coronary syndrome, you can see this narrowing over here, aortic dissection, and pulmonary embolism, the 3 main killers can be diagnosed with this one technique. Of course, PTX and rupture of the esophagus would also show up, which can also cause chest pain. Now, triple rule out CT is great when the presence of disease cannot be diagnosed by traditional means. And in terms of ACS, acute coronary syndrome, it is recommended for low intermediate risk patients. So, those are who are not that old, who are probably not smokers or do not smoke that much. And if we were to utilize this kind of technique with high and medium risk patients, we would see too many positive cases. And so for such patients, a cardiac stress test and angiography is recommended. This technique requires a good CT scanner with very thin slices, ECG gating and beta blockers, and a two-phase contrast media administration. And that means that the anatomical coverage is greater than for example, just a coronary CT. It means a greater dose. It means more contrast to the patient, and it also means a longer scan time. So you always need to weigh the risk to the benefits when ordering such a CT. MR imaging is the one which under no circumstances can be performed outside the radiology department. That's because the MR units need to be shielded in a special way to allow imaging. And so when you order an MR scan, that scan needs to be, or that patient needs to be transferred to the radiology department. Now, MR is utilized mostly in neurology because CT is not as sensitive for the detection of ischemia. CT is great to visualize hemorrhage because blood is bright white on a non-enhanced CT, so you would see that. But if there's ischemia, then there are of course delicate signs of ischemia, but they can be missed, or a CT might truly be negative in the early hours. Here you can see a patient. This is an axial image, and if you compare this area on the right to the area on the left, you can see that the area on the left lacks the differentiation between the white and the gray matters. So there is high suspicion of ischemia over here. But the DWI technique of MR is so much better because ischemia virtually lights up on the DWI minutes after the ischemic attack, and so patients can be treated much earlier. In terms of the spine, epidural abscesses, hematoma, and cauda equina syndrome are diagnosed most often. And I have mentioned in my abdominal talk that for appendicitis in pediatric and pregnant patients, CT is great, especially if ultrasound is not diagnostic and you do not want to do a CT for pregnant and pediatric patients. And lastly, hip MR is great. And we had one great story when an old anatomy professor, not the one who taught me or was the professor at the time when I was a medical student, but the one before him, with whom I share a last name, but we're not family at all. So he came in with right hip pain, and nobody would believe this, but his x-ray was negative. Then we did the CT because clinical suspicion was high, and then the CT was negative, and everybody got so anxious because, you know, there was this professor whom we respected and were a little bit afraid of. So we wanted to give him the diagnosis quickly and have him get his surgery as soon as possible. And so we organized a hip MR in about an hour, and finally it was revealed that he had a fracture. So he got his treatment, and this just shows you that sometimes these modalities might not reveal the true cause of pain. And so femoral head fractures, as I said, might not show up on X-ray or CT. 48 hours after the fracture, the likelihood of mortality rises, so you need a quick diagnosis so that patients can get treatment as soon as possible. Angiography is almost like surgery. These procedures are carried out in one of these special rooms. These are almost like operating theaters. The patient would be laying on this table with the team surrounding the patient. We have large monitors and a C-arm, which is basically just an X-ray source with a detector opposite to it. And we would treat these kind of patients. So here's one patient with occlusion of brachial artery. This is the site of the occlusion. And so what we did was we went in with a catheter and we placed a stent over the occlusion and opened up that artery, and now you can see that the brachial artery and its branches show good circulation. Another patient who originally received a CT examination and a large abdominal hematoma was revealed in front of the right kidney. Within the hematoma, active bleeding was also visualized. That's that focal hyperdense area over here. So the patient was transferred to angiography, and through the iliac artery, we first catheterized the larger arteries until we finally got to that one small artery which was feeding this bleeding. So the site of the active bleeding is visualized here, but we are too far away at this point from the site of the bleeding to occlude the artery. So you need to go further and do what's called selective catheterization. And through the catheter, we placed in a coil, and then you can no longer see that active site of bleeding. Before I finish, I would like to talk about imaging of polytraumatized patients and the shock room, which we have at Kennedy Hospital. So the shock room is sort of a mixture of an operating theater and a radiology suite, because there's a table for the patient to lay on, and you can imagine that at one time 15 to 20 doctors, nurses surround the patient. There are a lot of traumatologists, anesthesiologists, radiologists, and nurses surrounding the patient. At my hospital, in the shock room, we have an ultrasound unit and we have an X-ray unit. We don't have a C-arm like here. What we have is the CT gantry in another room next door. So if patients require CT imaging, they can be quickly pushed over to the room next door. And opposite to that, but also next to the shock room, is the true operating theater where patients can be surgically treated. So when patients are rushed into the shock room, no imaging is done in the first 5 minutes because patients require stabilization, insertion of catheters, etc. They need their clothing removed, for example, and so we don't do any imaging. We wait for the traumatologist to call us to do an ultrasound examination, the rush protocol, for example, or to perform X-ray imaging. If we see something that requires surgery, such as a lot of free abdominal air or laceration, rupture of the spleen, for example, then patients are moved to surgery. Of course, based on imaging, the surgeons can decide that patients are stable enough to be transported to a different ward for further treatment, or they can also decide that the patient needs further imaging, and then patients are pushed over to the CT room. Here are two images. The first is a supine chest X-ray of a patient with extensive surgical emphysema due to a pneumothorax, and this neck x-ray shows decapitation of the patient. In the 30th minute or before the 30th minute, a region or organ specific diagnosis needs to be made, and then based on that, surgery or further care is initialized. Within the first 30 minutes, CT imaging is usually done, and this can either be organ specific, but what traumatologists love is a whole body CT when patients are imaged from the top of their head down to the pelvic region. So that means that the head, the cervical spine, the chest, and the abdominal cavity are visualized, and you can imagine that that's a lot of images for the radiologist to process. And what makes it even worse is that as soon as we receive the images, the surgeons and the traumatologists are behind us demanding quick diagnosis, which can be demanding and tricky at times. So what we usually do is give them what's called a wet reading, when we go through the slices quickly and target certain areas. And so we can tell them that yes, there is abdominal fluid, which is blood, or there is laceration in the liver and kidney, which needs to be operated on, or we can talk about the fractures that the patient suffered. And then when these people, the surgeons, traumatologists, move away, and we have some calm time to do the thorough reading, we might call them back in about 10 to 15 minutes and add some more detail to our report. Beyond 30 minutes is when control images can be done, or MR imaging can be performed. And as I said, MR imaging is done in a different area of the hospital, and so patients require mobilization. And here you can see a patient who suffered trauma and suffered dislocation at the level of C4 and 5. This is a T2 image because the fluid, cerebrospinal fluid, is high intensity. In my talk, I talked about emergency medical service and how radiology can help with the care of emergency patients. What I didn't do, I didn't give too many examples. So I would recommend you to watch this video put out by the Royal College of Radiologists. It is a 40 to 45 minute long video with lots and lots of examples. And these two radiologists talk from experience. I think it's a great watch, so you should definitely take a look at it in your free time. And with that, I thank you for your attention. I hope you had a lot of fun time and you learned a lot throughout this semester. And if you become a radiologist, please let me know, send me an email, and maybe we can collaborate on something in the future. Take care. Bye-bye.